Welcome to the session entitled Lead Extraction and Abandoned Leads Best Practices and Technology Insights. We have a case to be presented by Ann Kroman from the Medical University of South Carolina, Charleston. But first, a warm welcome to our panel, Rohit Mehta from Charlotte and Oliver Monfredi from Charlottesville. Right over to you, Ann.
Thank you so much. And thank you, Devi, and all of the organizers. This is a fantastic, phenomenal program. I've enjoyed watching all the days so far. It's an incredible amount of cases by all of the presenters. Fantastic topics. And Devi, I'm continually amazed and impressed by you. I do not know how you do it all, but you're amazing. So thank you for the chance to be here. And thank you to my panelists as well, Rowan and Oliver. Looking forward to our discussion. I know this is something that is near and dear to all three of our hearts. And I'm going to be talking a little bit about lead extraction and the problem around abandoned leads, which is kind of becoming something that we're trying to move the needle on a little bit for understanding out in the world of EP and understanding kind of the implications of abandoned leads and why it is important to think about lead management overall as a whole and to start kind of talking and working with our referrings and our implanters and try to help address this problem. So when we think about, when these are my disclosures, none of which are relevant to our discussions today, but when we think about capped and abandoned leads, is it really a problem that we're trading off a short term gain, meaning it's easier just to say, oh, I'm going to just leave that pacer lead alone and upgrade the patient to an ICD, and we're just not going to worry about it? Are we really trading these short term gains for longer term problems overall? So we really want to look at what is essentially the clinical downstream of what happens when we have abandoned leads. And it is not as benign as it tends to seem. And I think that's part of the reason why there has been so much just capping and abandoning leads in the past is a thought that, you know what, it's safer. We're not putting the patient through an extraction, not doing anything risky. We're just going to take the safer road, so to speak, and just leave that lead alone and add more leads to the patient. But really, that short term benefit on the front end is exchanged for kind of a long term detrimental effect potentially to the patient. And we've seen through a variety of different studies that there are some differences in outcomes when we look at patients who either have an extraction or they have leads capped and abandoned and left behind. This is one from the Duke group with Dr. Piccini and Sean Picorni, showing a difference in association mortality by the group's extraction versus capping and abandonment, with a better improvement in mortality overall with the groups that underwent extraction. If we also look at the long term outcomes, we know that if we look at infection rate as well as venous system occlusions and potential thrombosis, again, we see that the kind of incremental even increase in these problems once we start to have a single abandoned lead or even multiple abandoned leads. So there's kind of a trend in the data overall through different ways that we look at it, that there's an increased risk of infection in these patients and an increased risk of thrombosis and venous complications as well. And what actually happens when those leads eventually do need to come out? And this is another side of the coin where we're looking at the future long term problems that has been sort of the trade off for sort of the short term gain, so to speak. And we know through another set of studies that leads that are abandoned lead to longer extraction programs if the patient does get infected or they do have a reason that we are needing to go out and do an extraction when we're having to take out, instead of just multiple leads, we're having to clean up a large mess of leads that have been left behind previously. Because a lot of these abandoned leads are older, they may have problems. So again, the complete procedural success of an extraction procedure go down when there's abandoned leads that are left present. The longer procedure, higher risk of complications and higher risk of potentially damage to the vein or damage to the tricuspid valve. And we've seen this through a variety of aspects. And I wanted to kind of point out, especially related to the tricuspid valve. This is a blow up from that teeny tiny graph showed before, but there's a higher percentage of damage to the tricuspid valve during an extraction procedure when there are multiple abandoned leads that often have to be removed at the same time. Again, kind of the suboptimal outcomes and a longer, more difficult procedure time and a higher complication rate as well. And again, just yet another study showing that our safety and efficacy of even mechanical extraction is more difficult procedure, again, in patients with multiple abandoned leads. So we've seen kind of a wealth of literature and data kind of supporting that abandoned leads do have an actual clinical consequence that I think is not readily discussed enough with patients overall. So now to get to our case. So this was a patient came to me. She's a 66-year-old female. She originally had a dual chamber pacemaker implanted in 2009 for sinus node dysfunction. She then, out of state, did a witness cardiac arrest at a hospital January 2013. She was upgraded to a CRTD during that admission. And again, we kind of pieced together records from a hospital we're not associated with, several states away. Also during that admission, she reported that what she was telling me, she said, "Oh, well, they took one of the leads out of my heart." So great, good, as we would hope they would consider and think about. She reportedly had history of low EF. Now it's recovered with good CRT. However, she's had some evidence of left ventricular lead fracture and noise with rising impedance. And so she has a Biotronic CRTD system. Again, this is the 2013 LV lead. You can see that there's a marked change in impedance, and there was clear evidence of noise on the lead and signs of lead fracture. As I like to do, I always trust but verify. And I think that imaging is important when looking at these patients. So we got a chest x ray on her. And of course, what do we see a little bit of a bonus surprise there. So it was true; it was out of her heart, however, not out of the vasculature. And kind of digging back into this, I see this often sometimes, and it's important to think about extracting leads. However, when we do so, we want to be clearly prepared to extract them. And oftentimes, this is a pattern that I have seen quite commonly, uh, because when we try to just unscrew the lead, sometimes people aren't prepared for extraction. Thinking about extraction, they think, "Oh, well, I'll just undo the helix and see if it comes back." But then if it doesn't, we're not going to do anything else. And then we kind of end up in this weird sort of middle situation, and then the lead gets cut, and then you just have this fragment, and it's often sort of caught at this very location. And the reason that it is why this happens, it seems to be a particular point that I see commonly. I'm going to ask my expert panelist here in a second what they see, but just to talk about the anatomy of it, I love this image. This is from a human cadaver section. So this is the innominate vein going into the SVC. It's kind of on the side, where the patient's head would be off to your left, and then down towards the heart over to your right. But you can see the lead through that area. And if you look at kind of that junction between the innominate coming into the SVC, there can be a little bit area where that sort of tightens up. And if we look again at the profile of the leads, we tend to think of them as very kind of, smooth and even profile. However, there can be a little bit of a step up there between the ring and the body of the lead. Some of this is actually built into it. And then some of that just sort of happens again a little bit with time. And you can almost get a little bit of a difference there. Seems to be just ever so slight difference of bulk that sometimes can get caught on a little bit of areas of adhesions and narrowing coming up from the SVC to the innominate. So just to ask Ro and Oliver, have you guys ever seen this come through your practice where you get kind of this exact fragment of a lead left behind?
Yeah, absolutely. And this is the precise location, as you point out. And I think in a lot of situations where you have additional leads in place, they're what we call ghosts. So basically, fibrous sheaths, if you will, that are in that location. And then the other thing is actually, quite honestly, direction of forces as you're pulling the lead without really a locking stud or anything in. The mechanism by which you're pulling, the forces are not aligned with the direction of the lead, and so oftentimes that'll also stick up. Other
Yeah, I've certainly seen leads get stuck in this position. I've also seen them get stuck more proximally. If we think about where we typically see venous stenoses, it's more proximal to this. And so when you pull a lead back and it frees up and it makes this turn, you think you're out of the woods, and actually then it'll get stuck just at the venous entry site. If you're not prepared to go all the way to take that lead out, I don't think you should be, pulling on it necessarily. I think it's important as well to mention, Anne made a great point about the differences in caliber of leads, and that's important to know that what the scenario is with the leads that you're using. It's also important to know that the biomechanics of leads is very different depending on the lead that you're trying to pull on. And there's some great data out there now as to what it takes to stretch the different kinds of leads that we have commercially available to us. And certainly I've factored that kind of thing in when I'm implanting a device, because I kind of focus on the worst case scenario that one day it's going to have to come out. And I think it's important to bear that in mind when we're choosing what leads to put into people.
Yes, absolutely,
Can I
absolutely. And thank
interrupt
you
and
guys
ask
for
a
the
question?
great
And
points.
no, I want you as a panel to tell the audience, is there any lead that you would consider okay with them, with anyone just pulling? Is there any lead? Is there any characteristic in a lead?
I think you've got to be prepared to
My
go all the
panel is
way.
silent.
But if you're going to,
yeah,
no, no. I think you've got to be,
yeah,
if you're willing to pull on a lead, then you ought to be willing to have to prepare that lead, to put a locking stylet down it, to prepare the insulation, and to use whatever tools necessary to take it out. I don't think I don't think you should be pulling on it, and then at some stage, if it gets stuck, then you're going to have to abandon it. I think if you do find yourself in this scenario in the field, I think it's really important to then know what to do with the lead, right? Not cutting, don't pull on it, cut it, and let it go back into the never never. That makes our life as extractors extremely difficult. I think, if you get yourself in this scenario, the lead gets stuck, then leave the lead as intact as you possibly can. Roll it up, put it back in the pocket, and send it to your local extraction center.
yeah. I think also, I think
And
there are
and
some factors just in terms of the age of the lead, the age. And we actually use implant age, so the age of the patient at the time they were implanted. That actually seems to be a factor that plays a role in this as well.
yes, no, I would agree with all of those because then you potentially get in this sort of situation, and then instead of doing exactly what Oliver had mentioned, it was just sort of left, and then left, years 10+ years down the road to now that she's has trouble with her LV lead, now having to go in and a little bit more of a mess to sort of clean up. So I had attempted to gain additional access. I like to do that a lot of times up front just to make sure, if I know that I already have a wire down for access, it just kind of takes one check mark off the board of things to think about and kind of goals to accomplish for the procedure. We did a venogram and she was occluded again, partially probably because a lot of that leftover bulk from that lead that did not need to still be in there. Um, and so you can see at this point going after the left ventricular lead first, using 14 French lasers sort of upsize, since I know that we will need to retain access to be able to reimplant. And this is just working. You can even see kind of all that lead on lead binding that we're dealing with there. You can see that kind of that area of the previous RV pacing lead that has been abandoned. make pretty good success getting down through. I can tell at this point that the LV lead is free and it's ready just to come out right away. So when I experience that, a lot of times I will try to buddy wire through, which is what I did here. You can see I have a VersaCore wire that's going down. I'll either use that or a glide, and that's precisely why I kind of upsized to the 14 French laser. So at least I now have something down. I tend to bury that down the IBC to the feet if I can, pretty much, so to speak, just to make sure of the large venous access that is still retained. So we get that going down. Yeah, there it goes all the way down. And once we get that fully down, then you'd see the LV lead. I think it's pretty much already there, whizzing out of the laser, and we get the wire still down. And now it's time to tackle that previously abandoned lead. Initially I tried the laser back again, but really kind of heavily calcified on that lead. Probably again, that one was, I think, an implant from 2006 or 9 or so, a much older lead from the original system, heavily calcified. I switched to the tight rail to get that out. And again, had to it made it for difficult prep of the lead because again, it had been cut, unlike what Oliver pointed out would probably be the appropriate thing to do. So I started really had to fish it out to get as much of that tip that I could to gain access to get a locking stylet down the lead, and barely had any access to the insulation. Had to use kind of more of a bulldog approach to get that on there, which makes it difficult, especially in this type of situations where you have lead on lead, where traction is really important. If you don't have as much of that lead to grab because it's been cut, then it can be difficult slog. And kind of just slow and steady, just working through with the tight rail. I love the tight rail. Tight rail is one of my favorite things. And then I think we get it in another flow store. And then we finally get that sucker out of there. So get that out of there like it should have been originally. And then got her nice new LV lead. And there is her final system.
And can I ask you a question?
Kind of just,
Can I ask you a question? Yeah, and I just saw that you just did a venogram. Is that routine for you before you pull it up?
The CS venogram?
Or did I miss it?
Oh, that was going back in with the new
new
LV lead.
Okay, all right. Does any one of you actually do a venogram before pulling the sheath out? You don't want to see what
before. Oh no, I don't. I had done one originally. That's where I knew I couldn't get another wire down for access, and so I had to retain access through the laser. But I usually don't do, unless I'm having trouble getting new access afterwards. Don't routinely do a whole venogram. Mm-hmm.
I agree.
Do you have any kind of mostly for like if you have any kind of hemodynamic not compromise. Sometimes it's you pull on the central venous system, you see pressure drops, whether it is because of injury or trauma or just pulling. Do you routinely do venograms to check, or what is your standard of care to figure out what's going on?
No, I mean, I am pretty slow and gentle. I mean, but even still, there's going to be some kind of trauma, obviously, to the venous system. We worry most about any sort of injury to the SVC, and I think with that, that's my first go-to. Then is to get that balloon up there and inflated. I always have the balloon, prepped and ready to go and back and staged in these type of procedures. I always, have some sort of echo imaging, be it ICE or TE or sometimes both. My anesthesia colleagues, they love their TEs, so they're relying on that. They're always, in the room, even when we're in the EP lab, and start to check. and we can get kind of a pretty good idea what's going on. And as my surgeons love to say when we're up in the OR, doing really kind of old leads, is they're always impressed. They always tell their CT surgery residents, they're like, a little bit of pressure on the venotomy site. They said, look how well non-heparinized blood clots. Isn't this amazing? So that they've always reminded me of just, how much if you're having especially just right at the access site, a little bit of pressure, and then some purse strings and hemostatic sutures will do.
Yeah, I think it's a great point about how the kind of differential diagnosis of hemodynamic instability interprocedurally. And certainly one of the things that we've noticed is that especially with large amounts of lead bulk, when the extraction sheath is advanced into the SVC region, you often have an occlusion of that superior venous flow. And so sometimes you can actually get hemodynamic instability from that. RV inversion is the other thing if you have good forces that are actually transmitting to the tip of the lead. And so, I think it's extraordinarily important to have some measure of imaging, whether that be TE, intracardiac echo, so you can see that. And then the other thing is in the setting where you do have a TE that's negative for effusion, but continued hemodynamic instability, fluoroscopy, especially on the lateral borders, just to make sure you're not missing an extra pericardial hemothorax, is really, really important to keep in mind.
Yep, absolutely. I always warn my anesthesiologist if we're testing the bridge balloon, and this is kind of a good sort of hemodynamic exercise too, but even kind of a pre-extraction testing of the bridge balloon, you can really see how that occludes preload, and you will kind of see that hemodynamic change. It's a great sort of lesson in physiology. And we've also learned that in patients that we're having to extract and they have really bad RVs, and there is, kind of a little bit of that RV inversion. And if they're having trouble kind of compensating, either when the lead comes out or, after we've relaxed on the lead, just because they've, a weak, sick RV, sometimes we'll even put the bridge balloon up and inflate it a little bit then, just to kind of back off that preload and give the RV a little bit of time to catch up. Especially if, again, really weak, sick RVs, that tends to kind of help them a little bit in that circumstance that we've seen kind of anecdotally noted. It's a little kind of side use of the bridge balloon, so to speak.
Yeah, I couldn't agree more about that point about the bridge balloon. There's a lot to be learned when you stage it. So you put it up into that SVC, you blow it up, you look at where the pinch points are, you look at where the leads are relative to the periphery of that bridge balloon, and you can learn a lot about how difficult or easy your life's going to be when you transition through that SVC. I just want to make the point, you made a lovely point about upsizing the laser to be able to retain access at the start of the case to get you access distally into the vein. We use a lot of rather than upsizing, we use a lot of VisiSheath with the laser, which is a great tool that Philips make, that allows you, once you get that, once you get the distal to where the occlusion is, you can pull out the laser itself with the lead and retain that outer sheath, which allows you to have free, unfettered access to that distal part of the vein. So just another way of making that happen.
Yes, absolutely. I agree. I like the VisiSheath for that, definitely. This was it. And if it had been a larger lead, instead of upsizing to a 16, my go-to would have been to use the VisiSheath over the 14. Absolutely. Yep, definitely. Right. I think I just had some final
Go back to
conclusion. Oh, go ahead.
Can we go back to end slides? Thank you.
Perfect. All right. And just quick, as we've all kind of talked about and addressed some of the downsides of capping and abandoning leads, potential electrical interference between the leads, venous thrombosis or stenosis, as well as device infections and kind of worse risk if we have to deal with those infections, and then increased complexity of the future extraction procedures. And then tricuspid regurgitation as well. The more leads we have through the tricuspid valve, the more difficulty we have with potentially damaging the tricuspid valve when we're getting them out, or even more leads causing TR. And I think that was all the points that I wanted to address. And then again, the MRI limitations as well. Thank you all.
And so, as you were finishing up, I was thinking about tricuspid regrowth, because I think that's come up as one of the newest and evolving fields where we're finally starting to get asked about leads, which is actually a good place to be rather than not being asked at all. So I do think that I think we're at least starting to have some collaborative discussions about lead management in these TR patients as we start thinking about things like TTVR and a lot of tricuspid interventions. What would you three are extremely busy with extraction practices. So what is your workflow when you are collaborating with your surgeon and your structural colleagues on how you're planning lead management in these TTVR procedures? And Olivia, I'll start with you.
We have a multidisciplinary team meeting where we meet every couple of weeks about these difficult cases, and we make sure that we run through the plan. Where jailing a lead is the very, very last thing that we'll accept to do. I mean, there are some of these tricuspid valve replacement patients who are so sick and have complex leads that tolerate a high-risk lead extraction. Sometimes seems as though it's beyond the pale, but we really try to avoid that at University of Virginia. And so we meet, we have very open dialogue with our interventional cardiologists. We're very fortunate that they are sympathetic to our mantra, which is, that we don't jail leads, that we figure out if there's a temporary solution with leadless devices that we have to go through before we then reimplant a more definitive device. Then that's what we'll do. We rely on the WISE CRT system when we have to for the leadless endocardial LV pacing, where we can't get resynchronization or physiologic pacing any other way. But yeah, that's really our approach.
Rohit, can I ask you a provocative question? Because it's the best thing to ask you.
Of course.
Do you think that as our structural colleagues set up tricuspid programs, should it be mandatory that there is an extraction program in that center as well? Or have some sort of collaborative platform set up? Because, I mean, there are guidelines to all these, all these programs as they evolve and they start up. Do you think the society should encourage that or make it almost mandatory?
Without a doubt, I think this is really represents a quality question. And the other thing is really, we don't think about informed consent. In this situation, this is really a risk discussion. And so one of the things we've done with our colleagues is really engage them to understand from a tricuspid perspective and RV perspective, what's the 1-year mortality for the patient? If that number is extraordinarily high, oftentimes we'll let them go forward and potentially even advocate for jailing leads in that setting. Because this is a palliative procedure, right? It's really for quality of life. In other situations, really what we want to impart to our colleagues is what is the risk of the extraction itself? Because oftentimes, a 2-year-old lead is often regarded as an extraction independent of risk. And so, a 2-year-old lead, a 10-year-old lead, a 30-year-old lead, there's no differentiation from other specialists in that regard. So I think that discussion is extremely important, that bidirectional education is important. So I do think having access to an extractor and extractors, at least for an opinion and the ability to engage the patient on that front and properly provide informed consent is really critical.
Well, that brings us to the end of this session. Thanks, Anne, for such a great case and lots of tips and tricks, and Rohit and Oliver for their expert contributions. Stay with us. US Focus Day 1 final session is coming right up.